Hello, everybody. Welcome to yet another series of webinars on thalassemia management. Good evening once again to all the participants who have joined in today and all our distinguished faculty members. Now, in this session today, we move to one of the very important themes of thalassemia management, which is towards successful fertility and childbirth in people with thalassemia. With improved survival and quality of life for people with thalassemia, reproductive health has emerged as a very central component of comprehensive care. So what we do today as pediatricians, pediatric hematologists managing thalassemia will have a generational effect on these people. If we manage them correctly, their reproductive functions, all their endocrine functions remain well within limits, and they go on to have a successful life ahead with both in terms of having if they wish, having a family and to have children as well. So issues related to pubertal development is what we'll discuss today. How to manage that, how to prevent any delay in pubertal development, how to manage in terms of, so after they become 18 years, essentially, we'll not be with the pediatricians anymore. So we have a multifaceted team today who has joined. It's almost like a multidisciplinary clinic actually today. We have medicine specialists who have endocrine specialists. We have high-risk pregnancy specialists who are joining in today to show how close coordination is important between pediatricians, hematologists, endocrinologists, obstetricians, and physicians and thalassemia specialists. So this is a session today, and I really hope it is helpful for all those who have joined in today, and we'll manage our patients better, much better. So to set the stage for our discussion, it's a privilege to begin with introductory remarks from Thalassemia International Federation. It's my honor to invite Dr. Michael Angastinoitis, a pioneer in global thalassemia prevention and care, and has a long-standing leadership role in international hemoglobinopathy programs. He has played a seminal role in shaping comprehensive care models for thalassemia worldwide. We request him to share his introductory remarks today to provide a global perspective on reproductive health in thalassemia. Over to you, sir.
Hello, everybody, and good afternoon, I should say, good evening, probably in India. You know, a good friend of mine, a teacher of mine, who's a thalassemia patient, because we have to learn from patients, once asked me, why are you keeping me alive? What's the point? I don't want to be sick all my life. I want to live only if I've got a purpose. If I've got things to do, normal things to do, like have relationships, like having children, like building a family, like working, like going to school. So basically, today we're talking about how do we give a chance? How do we satisfy this desire of our patients to be normal members of society? And one of the issues that are burning for them is the issue of relationships, the issues of growing up, the issues of building a family of their own, fulfilling whatever it is that fulfills every human being's life. So thank you very much, Dr. Nida, for this, for the choice of the subject. And I hope everybody sees it from the point of view of the patient. Thank you.
कितनी देर में कितने
Dr. Neeta?
Yeah, I can hear you, ma'am. I think there was some issue in the audio. Dr. Michael, would you want to continue?
No, it's okay. I think the message I want to put over, I hope, has been received.
Yes, thank you very much. I think there was some disturbance in the audio in between. So thank you, sir, for joining us today. Now we'll proceed with the context setting session. So it's my pleasure to invite Mrs. Shobha Tuli, Secretary of Thalassemics India and board member of Thalassemia International Federation. She's been a tireless advocate for patients. So families who have joined in and thalassemia treaters who have joined in from our country would know her very well. She does not require any introduction. So over to ma'am to kindly introduce the context in Indian setting for us.
Thank you, Dr. Neeta, for your kind words. Good afternoon and good evening to all of you. I'm very happy to see the participation in today's session. Over 70 delegates are already there. So welcome once again to the session 9, and which is the topic is successful pregnancy and childbirth in thalassemia. And I welcome once again all the experts who are present here from India and from overseas, Dr. Farooq Shah, Dr. Ritika Sir, Dr. Manisha Kumar, Dr. Bhanu Bakari, and Dr. Sudipta Bhattacharya, and my colleague, Dr. Neeta Radhakrishnan. I agree with Dr. Michael when he said that, well, you know, the patients and when they become, when they reach adulthood, they often ask such questions that what is the purpose of my life? And I will share with you one recent of my memories, you know, in early 90s. And there was a thalassemia conference in Delhi, international conference. And I was very particular that this subject should be added into the agenda. However, I got some resistance from the other colleagues and the doctors, but finally it was added. But once it was discussed, and I felt that, well, you know, the patients did not show that much interest in this topic, neither the families, the parents also. Maybe they were thinking that, well, it's too early to talk about whether we will be able to reach this stage where we can have, you know, we reach the motherhood and all that. But today, when we look at that, with the improvement in the thalassemia care, you know, overseas as well as in India and the other Asian countries, I think it's right time now. The patients realize, the families realize, and the doctors are, of course, very hopeful that, well, patients with the proper care can reach adulthood and the woman can enter into pregnancy, because we have seen so many children getting married and planning to have babies. Of course, this is a very, very important topic, as well as because it needs a lot of care from the hematologists and all the care, the experts, you know, are involved into this. And I'm very sure that the coming presentations and the experts will talk about the fetal monitoring. They'll talk about the chelation during pregnancy. They will also talk about the maternal transfusion and overall standard management plan. So thank you so much for having me here, and I'm very sure that we'll have a very fruitful session. Thank you very much, Dr. Neeta, and over to you, please.
Thank you. Introduce session ahead, very long for us to, and so we'll start with by Dr. Farooq Shah is currently consultant hematologist at the Berlin Medical City, and she's been working very closely with Thalassemia International Federation since decades, and as an author in many of the chapters that we have all learned growing up in thalassemia field. So she is a recognized expert, and she will provide her extensive expertise in clinical care as well as research in discussing valuable insights into fertility and pregnancy outcomes in thalassemia. And after the keynote address, we'll have a panel discussion. So like I said in the beginning, it's almost like a multidisciplinary team meeting today. We are very fortunate to have experts from different specialties join us today. So we have Professor Ritika Sood, Professor of Medicine at the Lady Hardinge Medical College and SSK Hospital, New Delhi, who will address the medical and systemic aspects of managing a high-risk pregnancy. And Professor Sood, so Lady Hardinge, for those who wouldn't know, the Department of Medicine takes over takes over adults formally as a transition of care. So I personally, a couple of our patients have been transitioned to her center, because it's very important that as they grow up, they are being managed by experts in each of the multidisciplinaries. It's no longer pediatrics now, it has to move to an adult facility. So welcome, ma'am. Then we are joined by Professor Bhanu Kiran Thakre. He's Professor of Pediatrics and Pediatric Endocrinologist at our center. So at our institute, we have once in a week, that is on Wednesdays, we have a pediatric endocrinology clinic where generally thalassemia patients attend this program. And we have been very fortunate to have him look after our thalassemia patients. So he'll discuss the endocrine aspects in pediatric age group, adolescent age group, and pubertal considerations. And then we have Professor Manisha Kumar. She's Director Professor and Lead Consultant in Fetal Medicine, again from Lady Hardinge Medical College, New Delhi. And she will deal with the obstetric aspects, the fetal medicine aspects. So again, very fortunate to have both fetal medicine and obstetric aspects being discussed by the same person. So welcome, ma'am, to our program today. And for this panel discussion, every time we select few cases. So we have a few cases which have been selected by our fellow, Dr. Sudipto Bhattacharya. He will anchor our discussions, as in we'll have a case followed by a few discussions. And finally, we'll discuss a little bit on the pregnancy aspects and delivery aspects separately. So I look forward to an engaging and insightful discussion. And over to Dr. Farooq Rashad. Thank you.
Thank you very much. I'm just going to share my slides. Hopefully you can see my
Yes.
right. Okay. Oops. Continue to share. Okay, so basically I'm going to talk about the guidelines, the British Society of Haematology guidelines on the conception and management of pregnancy in patients with thalassemia syndromes. And the guidelines are very comprehensive. They're written by a multidisciplinary team, including our obstetric colleague, Ms. Amakai Mensah, who's managed almost all the pregnancies at the Whittington Hospital, Dr. Karen Anthony, who is our endocrine specialist, particularly with an interest in male fertility. And she helps all of our young men go through spermatogenesis induction. And Mr. Gidon Lieberman, who is our female fertility specialist, who helps all of the ladies who go through ovulation induction, as well as my hematology colleagues, Dr. Shivam Pancham, Dr. Sarah Nicole, and Mamta Garg. So it's a very multidisciplinary group, and the guidelines were actually reviewed by the Royal College of Obstetricians and Gynecologists, as well as the Endocrine Society, to make sure that all of our multi-professional colleagues were, were approving of the guidelines and actually ratified them. So I have no relevant disclosures for this talk. And I do want to just, as Michael said so well, the context is so important. And a few of my patients very kindly gave videos when I presented the guidelines initially. And I'm just going to play
I'm
the
Nisha.
video for you.
I have beta thalassemia major. I'm 46 years old. I work as a GP. I had fertility treatment back in 2012 to have my son, Rishi. He's now 11 years old. He is the best job for me, being mum, essentially. He keeps me going, gives me pep in my life. Going can get tough a lot when you're dealing with a chronic health condition. And, just seeing his smiley, happy face just keeps me going. And, I get very emotional when I talk about him because he is my everything. Hi, my name's Maria and I'm a thalassemia patient at the Whittington Hospital in London. Becoming a mother was something I always dreamed of from quite a young age, and I knew that's something that I wanted. But having thalassemia, I wasn't sure that would ever happen for me, if that was possible. However, once me and my husband got married, a few years later, we decided that it was the right time for us to have a child. I spoke to my medical professionals and I put in all the hard work. I looked after myself. I made sure I was collating perfectly. I attended all the medical appointments that I needed to, and all the extra ones that come into play when you want a baby. And I really took care of myself, my diet, every element that I could. I tried to get it as perfect as possible so that I could begin that journey. In 2014, I started fertility treatment at the Whittington Hospital. And in August of 2015, our dream came true and our gorgeous baby boy, Leo was born. Becoming a mother has been the most rewarding and incredible journey I could ever have embarked upon. Nothing else I've accomplished in my life even begins to compare to the gift of motherhood that I was given.
So I think that puts beautifully into context why having a really clear guideline for what to do to support our patients as they enter puberty, adulthood, and then move into starting families is just absolutely so important for patients. And it really changes their perspective on life and their chronic health condition as well. So as I said, the guidelines are actually really comprehensive, and I do encourage everyone to go through those guidelines when they've got some time, but they specifically cover things like puberty induction, they cover spermatogenesis induction, ovulation induction options and regimes, as well as going into more detail about the management of pregnancy itself. The guidelines, and for the purpose of the talk today, I'm really going to focus on these 4 key aspects, which is preconception, management and optimization of patients, assessment and management of hypogonadism. But I'm not going to talk in detail about the drugs or anything. Those are, it's a very complex area that requires expert input from endocrinologists to manage. And then I'm going to talk about management of pregnancy and how we can optimize outcomes. So the guidelines are full of tables. And what's really important to remember is that patient optimization is a multi-step, multimodal, multidisciplinary approach. And you have to include in there genetic counseling, making sure that the partner has been tested, and that you know what the risk categories are, assessments with the fertility unit for both male and female factor fertility. So your thalassemia patient's spouse or partner has to also undergo appropriate testing and screening, making sure that patients are taking contraception if they're naturally fertile, so that pregnancies are planned and not accidental. Psychological and lifestyle assessment to try and help them optimize their health outcomes. As Maria so beautifully put, she became 100% perfect in the lead up to her conception attempt. Iron chelation needs to be really optimized. I don't chase ferritin targets. I chase the liver iron. So the liver iron is actually very important in affecting outcomes of patients. And then transfusion regimes really need to be optimized for the thalassemia major patients. We aim for a hemoglobin of about 100 during the pregnancy, and that means a hemoglobin of 10 essentially. But with the non-transfusion dependent patients, the situation is obviously much more complex and requires an individualized approach with regards to that aspect. Cardiac preconception optimization means you need to be aiming for really well-controlled cardiac iron burden as well as hepatic iron burden. And you do need to make sure that your patients' virology assessments are up to date and ensure that they're appropriately immunized, plus on appropriate treatment if they need treatment for a viral infection. Endocrine monitoring is absolutely essential in patients, and diabetes optimization goes hand in hand with thalassemia optimization. And then there's a load of medications that our patients take that they should not be taking during or even in the lead up to pregnancy. And in particular, drugs like bisphosphonates, ACE inhibitors. And in India, it's not in the guidelines, but obviously there are patients in India who are on thalidomide, hydroxyurea. Those medications need appropriate adjustments prior to any pregnancy. So what are the targets for successful outcome? Well, the primary target, of course, is lifelong prevention of iron overload and optimization of iron burden going into pregnancy, because women will have 9 months of inoculation if everything goes to plan. And for male for male patients, depending on their anxiety levels, you may want to either continue or change iron chelation therapy. It's really important to avoid accidental pregnancies, because obviously you're then going in on a pregnancy for 9 months without well-controlled iron burden, maybe with exposure to drugs that should have been stopped beforehand, and avoidance of preventable complications such as red cell alloimmunization is absolutely critical when you're thinking about what to do with females when they are pregnant, because if they've developed red cell alloantibodies, you introduce additional risk during the pregnancy. So my target for all of the patients, and the guidelines target, is a liver iron of below 7 going into pregnancy, and the spontaneous transition into puberty in patients will make pregnancy planning very, very easy. My target at the Whittington, and certainly wherever I work, is a liver iron of below 5 for patients when they go into pregnancy. So we should aim for a T2 star above 20, but girls do get pregnant with liver iron with cardiac T2 stars of 7. And these are, quite often unplanned pregnancies. And you then have to be able to manage patients who've got cardiac iron overload as they are going through the pregnancy, particularly around reducing the risk of them going into heart failure and developing cardiac arrhythmias. Spontaneous pregnancy in a patient whilst they're taking iron chelation is not an indication for termination due to exposure to the iron chelator. So that's really important to remember, whether that is deferiprone, deferocyrox. Patients should not be terminating pregnancies, because the risk of actually any kind of fetal anomaly with iron chelation drugs is primarily theoretical. It's not been confirmed in any pregnancies that have happened so far in female patients who are taking iron chelation therapy. So what we advise is that females stop iron chelation as soon as they have a positive pregnancy test, if this is an accidental, unplanned pregnancy. Patients who are going through ovulation induction and IVF pregnancies, these are really regimented. They're seeing the hematologist, they're seeing the obstetricians, the patients are on Desfral during the cycle. So there's very limited risk of them being exposed to either of the oral iron chelators during pregnancy. And it's incredibly important to optimize diabetes control and thyroid function, particularly in female patients as they enter pregnancy, because we all know that the presence of insulin-dependent diabetes is associated with independent risk factor for poor outcome in pregnancy. So there are also male-specific issues. So if naturally fertile and they're planning a pregnancy, as per the summary of product characteristics for the individual chelation drugs, the recommendation is to stop oral iron chelation regimes and switch to Desfral before attempting a pregnancy. I can tell you that the vast majority of gentlemen will not do this, and they will just carry on because they are naturally fertile and they don't know when their partner is going to get pregnant. But, it is what it is. But the guidelines recommend, because we have to, as per the SPC recommendations. Patients undergoing spermatogenesis induction, they need to continue with their existing regimes. Spermatogenesis induction can take up to 2 to 3 years in some patients, and you cannot have them on Desfral the whole of that time. So we recommend that they continue on. Hello?
Yeah, we're just trying to find out who it is.
Okay. All right, thank you. So we do recommend that patients who are undergoing spermatogenesis induction, in the 6 weeks prior to any sperm cryopreservation or any planning of pregnancy, that is the time when we recommend that they switch to the Desfral therapy. The other thing that I think is really important is that the times when I've seen spermatogenesis induction fail is when diabetes control is poor. And so it's very difficult for patients because they have to do 2 things together and control both things together. So getting on top of the diabetes control in male diabetic patients undergoing spermatogenesis induction is really critical. And I do tell my patients that sperm does not grow in sugar, and it's really important that they target perfect blood sugar levels. So we recommend switching to Desfral 3 months to 6 weeks before semen cryopreservation. So I'm now just going to talk quickly about conception. So spermatogenesis induction is very important to ensure that you're doing baseline testing of the full endocrine panel, which is listed in the guidelines. It's really important to be very clear on the baseline testing that if your patient has got hypergonadotrophic hypergonadism, that suggests testicular failure, and patients are unlikely to respond to induction therapy. And these conversations need to happen early because there are other strategies that can be employed in patients who are in that particular situation. It's very important to stop testosterone replacement in a timely fashion. Gels, if the patient's using gels, the switch is immediate, but if they are on injections, you have to wait until the point when the next testosterone injection is due before you do testing and before you initiate therapy. And the other thing that is really important is that it can take between 6 months and 48 months for patients to respond to spermatogenesis induction. This is different to spermatogenesis induction in non-thalassemia patients. Non-thalassemia patients who do not have iron overload will often respond much faster. And normally the guidelines say up to 24 months. But in the thalassemia patients, you do get delayed initiation of spermatogenesis induction. Almost all of my patients who've gone through spermatogenesis induction have needed both FSH and HCG to get an optimal response. This is really challenging for the men because they're having to inject several times a week. So it's really important that you're working with them around the therapies that they're having, the frequency of the injections, how they're doing with their iron chelation and with their diabetes management. So management of conception in females should be as per the NICE guidelines. These are obviously UK guidelines. So NICE guideline 156, very comprehensive, almost 100 pages long, with very clear instructions about what to do with females undergoing conception. So again, in females who've got hypergonadotrophic hypergonadism, that means a high FSH or high LH with low estradiol, these patients are going to be resistant to fertility therapy, and you have to manage them as per the NICE guidelines. Now, the vast majority of thalassemia girls are hypogonadotrophic hypogonadism, and ovarian reserve, that's the AMH levels, they can be actually very low, and it's really important that you do not discount a low AMH as being something that says this female is not going to be successfully able to conceive. The AMH level is reflecting an ovary that is not being stimulated. And so when you stimulate the patients with thalassemia major, they actually do quite often very well with ovulation induction therapy, and you will get a very, very nice number of eggs developing when you start stimulation in a lot of these young women. And in fact, in our center, the vast majority of females will get pregnant between the 2nd and the 6th cycle of ovulation induction. And very few of them actually need to proceed to IVF. Some do, but the majority will get pregnant with ovulation induction. So management during pregnancy, the guidelines again are very, very comprehensive. They tackle all key aspects of managing pregnant patients. In patients who have had a history of cardiac iron overload, it's really important to remember that they may develop cardiac arrhythmias during pregnancy, even in the absence of cardiac iron overload, because the arrhythmia is because of damage that has been done previously. So you have to take the cardiovascular symptoms that a female comes to you with very, very seriously. So these are very high-risk pregnancies. They require a multidisciplinary team to deliver general and thalassemia care, and decision-making really needs to be shared. And certainly, my own experience of leading a lot of women through pregnancy is that the obstetricians, the midwife, the hematologist are absolutely working hand in hand. And then the diabetes and the diabetes nurse specialist or the diabetes expert, along with the cardiologist, are playing a very important role in the midst of this if they are needed. A lot of the younger women will go through pregnancy without any major issues because many of them have not had significant levels of iron overload when they were younger. But some of the older females, certainly at Whittington, are thalassemia patients who are above the age of 35 were more likely to have significant complications during pregnancy. So again, antenatal guidelines should follow the NICE guidelines. There's a very nice table in the BSH guidelines which lists what should be done at each individual week for the thalassemia patients who are going through a pregnancy. And pregnant patients with thalassemia need to be reviewed monthly, weeks of gestation, and fortnightly thereafter. And this is equally relevant for both the transfusion-dependent and the non-transfusion-dependent patients. Thromboprophylaxis is very important. The VTE risk is raised, especially in splenectomized patients with beta thalassemia. The non-transfusion-dependent thalassemia patients are at highest risk, and the transfusion-dependent patients, they are at high risk, but their risk is slightly lower. So the guidelines actually recommend that all women are offered aspirin, 75 to 150 milligrams from 12 weeks of gestation. But aspirin is actually very important in the splenectomized patients, and you should be really thinking potentially about the higher dose in those patients. Patients with a prior history of thrombosis need to be managed as per the RCOG guidelines and have a risk assessment and a decision about the use of low molecular weight heparin during the pregnancy and how and when it should both be initiated and used. The prothrombotic state in alpha thalassemia, so that's hemoglobin H, it's less well clearly defined, and patients do need to be managed on an individualized risk assessment basis. Thrombosis risk assessment should be undertaken at the initial antenatal visit, 28 weeks gestation, and during any admissions. And all females who are pregnant, who are admitted as an inpatient, should be given low molecular weight heparin during the admission. So chelation therapy during pregnancy, the vast majority, this is about 80 to 90% of females, if they've been properly prepped prior to pregnancy, and this is not an accidental unplanned pregnancy, they will be able to go through pregnancy without needing any iron chelation. There are patients that we do chelate. So patients with cardiac iron loading, so that's a T2 star of below 10. These patients should be started off on Desfral, a minimum of 4 to 5 days a week. Generally, the dose we're using is 20 milligrams per kilogram per day as a subcut infusion. And we normally will start that somewhere between 20 and 24 weeks of pregnancy. We have started this earlier in patients with very severe cardiac iron loading, but that is on an individualized basis, depending on what is happening with the patient, what their ejection fraction is, if they've got any cardiac dysfunction, if they've got any cardiac arrhythmias. In any patient with thalassemia who's got cardiac decompensation or a more than 10% fall in the left ventricular ejection fraction from baseline, or they've got clinical features suggesting heart failure, or they develop a cardiac arrhythmia, they should be started off on Desfral intravenously 24 hours as an infusion, and you should be considering optimal doses, taking into account the gestation of the pregnancy and the risk to the mother. So we try not to go to the maximum doses in the vast majority of patients who need iron chelation, because obviously we're concerned about the impact of iron chelation on the fetus. but in a woman who may decompensate and go into heart failure or already has features suggesting heart failure, preserving the life of the mother is actually extremely important. In severe hepatic iron loading, the decision for iron chelation is very individualized. So babies do take a lot of iron from the mother. So usually what happens in the first 4 months of pregnancy is that the ferritin doesn't go up that much because the fetal development is using a lot of iron from the mother. But we do consider iron chelation therapy in women from around 20 weeks of gestation, but this depends on the severity of the iron burden. Normally, I will start iron chelation if the liver iron is very high, and we're talking about a T2 star of below 2 milliseconds. And generally, I'm more likely to start it when it's 1 millisecond rather than 2 milliseconds. So intrapartum care should follow local and national guidelines for both induction of labor and intrapartum care in uncomplicated cases. And again, we reference the NICE guidelines. The risk of patients developing cardiac failure and arrhythmias are higher in the peripartum, postpartum period because of all of the stresses related with labor, the fact that there's been no iron chelation for 9 months in the majority of patients. So the guidelines actually recommend peripartum chelation therapy in patients with transfusion-dependent thalassemia, mainly to reduce the presence of non-transferrin band iron, which can cause free radical damage and stimulate a cardiac arrhythmia during the stress of labor. So we recommend 2 grams given intravenously over 24 hours from the time that the female patient is admitted into hospital in labor or is about to be induced. Postnatally, obviously, we no longer need to worry about the baby because the baby is out. So we recommend patients continue with IV or subcut Desral whilst they're in hospital. If they're breastfeeding on discharge, we recommend that they increase the iron chelation frequency up to 5 nights a week using 40 milligrams per kilogram per day of Desral. By somewhere between the 4th and the 6th week, we don't ask them to do it from day 1. It's hard enough to manage the baby. Having to manage iron chelation makes it much, much harder. So we encourage them to build up their frequency of chelation. If the patient is not breastfeeding, then we put them back onto their pre-pregnancy iron chelation regime. And this is at iron reduction doses. So that generally means deferocyrox at a dose of 21 milligrams per kilogram per day or higher, or deferoprone at a dose of above 75 milligrams per kilogram per day. And Desral, we will definitely encourage patients to do at the proper therapeutic dose. So thromboprophylaxis, we recommend for 6 weeks for those who deliver by cesarean section, and also for 6 weeks in women who've had a splenectomy and have a high platelet count, or any female who's had a venous thromboembolic event or for any other reason. So VTE prophylaxis is as per patient's risk category in non-transfusion-dependent thalassemia patients, and formal postnatal assessment for non-transfusion-dependent patients needs to be undertaken. You also at that time need to be thinking about what the ferritin is and organizing for MRI assessments. It's an individualized decision to chelate patients, but it's usually not a crazy rush because most of the non-transfusion dependent patients, if they do end up needing blood transfusion regularly during their pregnancy, it's usually at a lower intensity because they've got a higher baseline hemoglobin. And although they do develop iron overload, it is not as much as the TDT patients. So we recommend that they resume preconception general management regime after the delivery, and then we initiate iron chelation at somewhere between 6 weeks and later. And just on a final note, pregnancy planning and parenthood isn't always something that is straightforward for many patients. And sometimes if they cannot conceive successfully through spermatogenesis induction or ovulation induction, you need to work with your patients on other strategies.
Hello, my name's Vikas Kokar. We had to somehow make our life complete, and the only way that we felt to do that was to have children. So we made the decision that we were going to adopt children, and adopting our boys, you know, it's just changed our lives so much. It's given us purpose, like I said. It's made me ensure that I take care of myself, both physically, emotionally. I go to the gym, I work out, I make sure that I'm healthy. I keep on top of all of my medications, everything, because I have a purpose. I want to live longer for them. I want to give them whatever I can. I mean, I'm thinking about the future. I know they're very young, my children, but I'm thinking of the future. I want to grow up to see their children, you know. Hello, my name's Vikas Kokar.
So I just want to end by saying thank you all very much for listening, and I'm really happy to answer questions during the panel.
Thank you, Dr. Shah, for that comprehensive discussion on how to manage fertility and pregnancy in people with thalassemia. So I think we will take all the questions at the end. So we will have a panel now, and I would request Dr. Sudipto to share the slides and to the ECO team to pin the panelists as well. So we will start with case 1. Yes. Dr. Sudipto, are you able to share the slides?
Ma'am, just give me a minute, ma'am. I'll just share, ma'am, right away.
Okay, so I'll wait. I think there's some technical issue. I'll share from my side. So we are starting the panel discussion now. I would request Sudipto to kindly present the first case. And we have all the panelists. We have Dr. Ritika Sood, Dr. Manisha Kumar, Dr. Bhanu Bhakti, who have joined in, and Dr. Farooq Shah. Sudipto?
Yes, ma'am, I can. I'm just sharing my
You can
screen,
just,
ma'am.
you want to do that? Okay.
Yes, ma'am.
Sudeep, meanwhile, while you are trying to upload your slides, can I upload mine? And because just to build up a context about a little endocrine context in the background.
Yes, sir. Go ahead.
Okay. So, are my slides visible?
Yes, please.
Yeah. So this is the hypothalamo-pituitary gonadal axis, which we all have read in our physiology classes. And just a brief overview is and so you know that in the age for both male and female, and that age is not a calendar age, it is the mental age of the. So senses that now it is the time to start pulsating release of gonadotropin releasing hormones, which activates pituitary, and pituitary releases gonadotropins, which we call as LH and FSH, and which in turn go in sync and stimulate the gonads. Now, the gonads, testes in male and ovaries in female. Now, we have to understand that gonads have primarily two separate functions. One is gametogenesis, and second important function is production of sex steroids, primarily testosterone in males and estrogen in females. And so these sex steroids, they have a role in giving rise to both the changes, the internal as well as external secondary sexual characteristics. Along with that, also these sex steroids, they help in maturation of the body clock. So as we were discussing about that, the hypothalamus senses as a particular body clock time, right? And another important context in this aspect is we have to understand that maturation of reproductive function, the body looks at it as a kind of resource intensive luxury kind of process. So whenever body senses that there are not enough resources or the conditions are not favorable for long duration, which may happen in the setting of thalassemia along with say celiac disease or even anemias and number of other chronic conditions like infections like tuberculosis, the body may not trigger the onset of puberty. So that is one very important context we should understand before proceeding further. So I'm stopping to share right now, and I might share again later. Over to you, Sudipto.
Thank you, Dr. Bhanu. So we'll go to the first case. Dr. Sudipta, kindly start the presentation.
Yes, ma'am. So this is the first case. The case was a case of NTDT phenotype with poor chelation and primary amenorrhea. And she was 16 years female child and had beta thalassemia intermedia and diagnosed at 3 years of age and was started on hydroxyurea at 6 years of age. Average hemoglobin was maintained around 7 to 8 gram per deciliter. There was variable chelation compliance, and she was evaluated for delayed puberty and amenorrhea. So she had this primary amenorrhea, and there was delayed puberty with poor progression, and she was having short stature with poor growth, with 136 centimeter at 14 years of age. That was the height. Chronic anemia of hemoglobin around 7 to 8 gram per deciliter. And there was hepatosplenomegaly present when we evaluated her, which was at 14 years of age. Child was initiated on regular transfusion at 14 years of age in view of poor growth and pubertal delay. So this is the ferritin trend. As you can see that around from 2023, she was having a pretty high serum ferritin of almost 6,800. That gradually came down to about 1,200 by almost end of December, end of 2025. So we had done a MRI T2 star finding. So she was having normal myocardial iron with cardiac T2 star 18.6 milliseconds, and there was having a liver iron of 1.12 milliseconds, which was indicating severe liver iron overload. So these are the endocrine evaluations. So FSH was actually low as compared with the follicular phase. LH was also low. Estradiol was low at 24 picogram per ml. But the thyroid stimulating hormone levels were fine. So we had managed this child with adequate chelation. We had initiated her on deferoxidox or deferriprone. We had maintained the hemoglobin at 9 to 9.5 gram per deciliter presently. She was started on thalidomide 1 year back. That was a trial patient. And she had and it's at 5 days and 5. So as you can see, this is the chart. So 68, that was 14 years. So she was having a height is to length, which was well below the -2 standard deviation, which has actually significantly jumped up to almost near to -2 standard deviation at around 16 years of age. BMI was almost the same during this period.
So thank you, Dr. Sudipta, for the first case, a relatively simple patient who has been managed as non-transfusion dependent thalassemia outside and came to us these are actually two siblings who came to us, a boy and a girl. So the girl, when she came to us, they were told us that she had not attained her menarche. So I'll start with Dr. Bhanu. How do we follow pubertal development when in an outpatient setting, when we are seeing children with thalassemia, either TDT or NTDT? As clinicians, what all should we be looking for at each visit?
Yeah. So, first of all, the criteria and the follow plan, evaluation plan is not much different from any other chronic condition. So, we follow the same guidelines as for delayed puberty.
Sir, sorry for
cutoffs.
interrupting you. Can you please increase the volume of your device?
We are able to hear, Prajat.
Ma'am, many of the participants have messaged. That's why.
Oh,
And
okay. Sorry.
I'll try to be a little closer. Maybe I've done it from my side actually. So, is it better? I'm trying to be a little louder.
yeah, sir, it's better now.
Okay, okay. So, the time when we should start screening and the way we should screen is not different from any other chronic condition which we monitor. So as it is for general population, that for girls the delayed puberty is defined once there are no first signs of puberty by age 13, and in boys by age 14. When we say the first sign of puberty, it is onset of thelarchy in females and enlargement of testicular size in males, and the testicular size we measure with the orchidometer, and the cutoff is 4 ml. So, and before that, although there are some endocrine guidelines which suggest that we should not wait for these cutoff ages to come, from 10 years onwards, every visit we should document the onset of puberty and progression of puberty. However, there will be some children in which the puberty might not appear by the end of these cutoffs. So that is the time when, because these cutoffs are based upon the normal variation in populations of the onset of puberty. So it is not really worthwhile exploring this condition in detail. However, it is very important to understand that the delayed puberty in thalassemia is multifactorial. Often when we talk about delayed puberty in thalassemia, the points which come into our understanding is that iron deposition in pituitary as well as in the gonads. But that is just one of a contributing factor. The first important contributing factor is, as we just discussed, that in any chronic condition, wherever body is sensing that something is not right, it is not, the resources are limited, so the puberty might not begin. So that is the primary problem with thalassemia if the management of the condition is not optimal, and that is very much evident from the data which is available, which shows that with optimal control, like in resource sufficient settings, it is seen that the incidence of hypogonadism is less than 10%. However, otherwise it is reported somewhere around 50%, even in most of the literature in India. So all during those follow-ups from 10-year onwards, it is important that the proper chelation, hemoglobin values, and so those are to be monitored. And not to forget that the condition of thalassemia or like any other chronic condition also brings certain other aspects. For example, we know that certain other hormone disorders. So if a child, everything is fine, but the thyroid is not functioning properly, there will be delayed puberty. Similarly, if the sugars are not fine, the puberty will get delayed. Apart from that, there is since there is a higher risk of getting transfusion and dependent infections, hepatitis B and others. So such chronic condition can also contribute to this thing, and especially the children which we see, which come with the delayed puberty as such, they are also likely to have nutritional problems. They are likely not to be involved much in physical activity, and which itself is a very good stimulant for the pubertal process. So, and along with that, some psychosocial deprivation. So these all factors contribute. So even when the child reaches to the cutoff of delayed puberty, after which we will do the detailed evaluation. But before that, several years, we have to make sure that the child is not having all these conditions. That is the time from 10 to 13, 14 years. Those years, all follow-ups, we should make sure. Not to forget the conditions causing delayed puberty which are prevalent in general population as such. For example, in adolescence, in our region, tuberculosis is quite common. So we in fact make a point that whichever child we see with thalassemia also with pubertal issues, we at least get a chest X-ray, because they might be having tuberculosis. So when we talk about detailed investigation, so once we have screened for all these things and we are sure those things are not there and still the pubertal onset is delayed, after that it is the time that we go ahead with the evaluation, and the evaluation primarily includes level of LH and FSH and testosterone and estradiol. Now, that is about, this case which Sudipta has presented very clearly highlight that as you said, that this child was being managed as a non-transfusion dependent one earlier, but later on when started on regular transfusions, so the puberty came. So again, if we talk non-transfusion dependent thalassemia also, if it is causing puberty, means body is ready for it. When underlying management of the condition of the underlying condition has to be escalated, and once it was done, the child was attained puberty.
Yeah, thank you, Dr. Bhanu. So yeah, the same point that probably we could have intervened early had the child come to us. So I'll come to Dr. Farooq Shah. In an NTDT setting, when you're seeing thalassemia patients who are traditionally labeled as NTDT, at what point do you wait for, as per your guidelines, growth delay, pubertal delay, these are all indications for stepping up transfusion. So do we need to wait for that to happen, or do you start early? Do you start when you start seeing growth faltering, do you escalate transfusions at that point of time?
That's a really good question. So we're monitoring the children very closely from about the age of 10 for the development of puberty. If they haven't really started properly, then we will definitely have a conversation with the parents about initiation of transfusion. Now, it's important to remember that in NTDT, if you are starting transfusions purely for puberty, patients can stop transfusions once puberty is completed and go back to their pre-existing baseline hemoglobin with their pre-existing hydroxyurea plus or minus thalidomide. So by the age of, as per the guidelines, by the age of 14, if they've not actually gone into puberty, we will definitely initiate transfusion. But the BMI chart is actually really very helpful, as well as the growth chart plotting. And if you see that there's evidence of them falling off the growth charts, as you can see from the charts that you've just shown, then we will often intervene earlier, because that's telling us that anemia is affecting the growth and development.
Yes, Dr. Bhanu.
Yeah, in this context, I would also like to add that bone age here plays a very important role. Bone age provides us a very important information, and say a child is having delayed puberty, bone age gives us an impression about the overall maturation status of the body, the age of the body clock. So say a child is having delayed puberty is there, and the bone age is delayed, significantly delayed, say at 14 years of age, the bone age is around 10 or 11 years, that indicates that something is wrong, even despite the fact that we have searched for the common things, something is there. Maybe the related to the thalassemia or some comorbidity, something is there. But on the brighter side, having a delayed bone age indicates that there is a good window of intervention left, which we can utilize and correct the things, and there are good chances of having spontaneous induction of puberty.
Yeah, so just to summarize, if we start children seeing falling off the growth charts, or
वो तो अलग है.
if we are seeing children falling off the growth charts, it's probably early intervention is indicated. I'll come back to this transfusion chelation question in a bit. We'll go to the second case quickly. And again, the first two cases have more of pediatric content, and then it goes to the adult patient. So over to you, Dr. Sudipto, for the second case.
Yes, ma'am. So this second case is a 15-year-old male child who was having transfusion-dependent thalassemia, TDT case, and he was on regular PRBC transfusion at our center, at a local center, and he was having delayed puberty and short stature, and was referred to our site for endocrine and growth evaluation. So this is the growth chart. So this is the as a mid-parental height was 165 centimeters, and as you can see that the growth chart, it was slightly creeping up, and there was some improvement in the growth velocity at the later stages of the chart, both for the height as well as the weight. So around 8 to 10 per deciliter, and episodes of hemoglobin with low 7.7. Although the recommended target was 9.10.5 per deciliter, but there was no significant hepatosplenomegaly, and CBCs were otherwise okay. So this is a ferritin chart. So as we can see that there was a one spike of ferritin at around 4,000. That was around July. Otherwise, he was maintaining ferritin around 1,400 over the last 1 year. So we had this endocrine evaluation. So we had done this T3, T4, and TSH, which were in the normal range. And there was an intact parathormone level done, which was 5.5 picogram per ml, which was low. And morning cortisol levels were adequate with a level of 12.6 microgram per deciliter. And fructosamine levels were done, which revealed 250 micropol per liter, and was within, there was no current dysglycemia. So this child had growth below the third percentile, and we had maintained a higher transfusion hemoglobin target, and he was on continued dual chelation, and there was delayed puberty, for which child was started on testosterone induction therapy. A regular endocrine follow-up was done for growth and puberty. Presently, the testicular volume actually had increased to 6 ml by December 2025, which was 4 ml in April 2025. There was improvement in the growth velocity observed, which I had already shown you on the growth chart.
So I think we'll start with the growth chart. I would request Dr. Bhanu to kindly discuss the growth chart once for all of us, the non-endocrinologists who are joined in. How should we generally follow up a thalassemia patient? Can we expect the same height and weight as per mid-parental centiles, or do we are they otherwise low? As in some other conditions, do we expect a lower growth compared to their growth potential compared to their mid-parental height? Over to you.
Yeah. So mid-parental height remains our kind of guideline, kind of that we aim, and that tells us that the child should remain somewhere in that range. Now, if we look at this growth chart, I see one thing which is good and one thing which is bad. If we talk about good thing is that with time the child is growing, at least in with the growth rate which is parallel to the growth lines, isn't it? So that indicates that despite the fact that there is a gap, the growth velocity is maintained. So the child is having the child is still growing every year it is going up in the parallel to this. But the bad thing is that definitely from the mid-parental height there is a gap. Now, to properly understand what is happening, the bone age here becomes a very important investigation. In such situations, we expect, so answer to your question, as you asked about the prognosis, that what should we expect, that whether there will be the final loss of few centimeters and child may not reach to mid parental height potential ever, or there is still some hope. So the bone age is going to very clearly answer that, because if there is a significant delay, then definitely there are the reasons could be multifactorial, and exactly that same thing happened here when this child was supplemented with testosterone. So what happens that many times testosterone, it is also given to kind of push up the process. So it is something like that, the pubertal process is just at verge. So what happens that if the puberty is also delayed, since the earlier the testosterone volume was in pre-pubertal ranges, there was no pubertal growth, pubertal spurt as well. So now with the testosterone, there is an overall maturation of the say body clock, and with that a push in the puberty. And as we know from physiology that usually the boys get the pubertal spurt at the later part of the pubertal window as compared to girls. So in the girls, when they show the first sign of puberty, if within next 1 or 1.5 years they are likely to be in the pubertal spurt, growth spurt. But in the boys, it is likely to be after 1 or 2 years at least. So still there is a very good hope that this child is likely to, since the spontaneous onset of puberty is there, 4 ml to 6 ml means, and we have just given testosterone. So we have to understand this, that the role of testosterone is to induce, number one, some secondary physical characteristics, some change in the body, body mass index, some improve in the muscle mass. So those things are there, some hair growth, and along with that, by pushing the overall maturation level, it has induced the puberty by itself. So from 4 to 6 ml is a very good sign that there is a spontaneous induction, although we call it as induced by testosterone, but actually it is the child's own mechanism has switched on now because the testicular volume has increased. And this is very likely that if there is a very good prognosis here.
Thank you. So the next question is, I would request I think both Dr. Farooq Shah and Dr. Bhanu to reply. As in, till when can we induce this? So we see a lot of children who come like 18 years, 17 years, 18 years with significant growth delay and pubertal delay, or TANA 1 or 2. So till when can we do this pubertal induction?
Shall I start first then? So
please, ma'am. Please, Dr. Farooq.
Yeah, so I think as Dr. Bhanu has said, the X-ray for bone age, but also in the older male patients, you need to take the X-ray of the knee to look at the epiphyseal growth plates. So the answer is you have to induce puberty regardless of, because you need to develop the secondary sexual characteristics. Okay, so that's the really important thing. There is nothing worse for a male patient to be at the age of 21 and still look like a 14-year-old. So regardless of where they are, you have to start them on testosterone. However, if they have significant bone age delay and their epiphyses are not fused, then you've got growth potential, which is really, really important for these patients. And what you should then do is use low-dose testosterone priming so that you don't fuse the epiphyses and you actually allow the skeleton to grow and the young gentleman to enter puberty and progress through an appropriate growth spurt. And I'm sure that Dr. Bhanu will add into all of this. But I think, at all points, bone age X-ray of the knee for the epiphyseal growth plate, and then you either go in with proper doses of testosterone because you're just developing secondary sexual characteristics, or you go in with low dose induction to help them go through a proper growth spurt.
Yeah, very rightly said. And this is very important point you have made, Dr. Farooq, and everyone should be aware of this fact that that we should be aware of the fact that the sex steroids, both testosterone as well as estrogens, they have their effect is like maturation of the bone as well as the fusion of the growth plate. So it becomes a difficult situation if there is a short stature as well as pubertal delay, because in those cases the low doses are to be continued, and in fact the other factors for short stature should be fixed first before going to sex steroids. And yes, from being a pediatric from a pediatric background, my understanding about the age till which we can induce puberty, I think as long as the bone age is say less than 18 years, I think I will do it, and beyond that I will refer to adult endocrinologist.
Yeah. So that brings me to my transition question to Dr. Ritika. So, ma'am, in your clinic, when you follow up adolescents and adults with thalassemia, I don't know if you've done it, formally assessed it, but according to a ballpark figure, what percentage of people have pubertal delay and hypogonadism, if you have tested it?
Yeah, so we do routinely look at the gonadal functions so we like the patients start coming to us at 18 years of age, and so they have already been assessed in the pediatric setup, and so some of them are on maybe low doses of hormone replacement therapy, and more than the females, I've seen that a lot of boys are on testosterone when they come to us. And for the girls, they are probably on for multiple reasons, not necessarily always for gonadal failure, but probably to improve the bone health and various other these things. So they are also on contraceptive pills, and there is a handful of them who are also on estradiol when they come to us, and we do continue to monitor them. So some of them who are doing well, we monitor them annually. We do their FSH, LH, estradiol, and various other endocrine functions. As a routine, we do them annually, but sometimes if the need arises, maybe 6 monthly, or depending on the kind of treatment that needs to be monitored and looked after. So if they are on thyroid medication, then we do that more often. So 6 monthly, we look at that. Otherwise, it's an annual routine to look at their FSH, LH, and estradiol and testosterone in boys.
Thank you, ma'am. So with that, we come to the next case. So we have 2 more cases and some discussion on pregnancy after that. So over to you, Dr. Sudipta.
Yes, ma'am. So case number 3 is a case of transfusion-dependent thalassemic who is married and is having secondary amenorrhea. So this patient is a 30 years female patient. Weight was 45 kg, diagnosed with transfusion-dependent thalassemia major, and on regular transfusion program since childhood. She was married recently in last year, November. She was started on transfusion at around 7 years of age, but current frequency is around 15 to 18, every 15 to 18 days. Annual PRBC loading was 256 ml per kg per year, and she's on oral iron chelation with deferasirox at 40 mg per kg per day and deferiprone at 88 mg per kg per day. So we had done a MRI T2 star at Feb 25, which showed a very good cardiac T2 star of 42.3 milliseconds, whereas liver T2 star was showing 6.26 milliseconds in a suggestive of a moderate liver iron overload. Left ventricular ejection fraction was 59%, whereas the right ventricular ejection fraction was 56.8%. So she was having menarche at 16 years of age. Initially, the cycles were regular. She was evaluated at 2022 when she was having irregular menses and ultrasound revealed ovarian cyst. From 2024, she is having amenorrhea, and presently she is desirous of pregnancy, and concerned about of children having chances of thalassemia. So endocrine evaluation was done. We had found a TSH level of 9.2, which was which was suggestive of a hypothyroidic stage. Prolactin was 14.4, which was normal. FSH and LH were elevated, and the AMH levels were markedly elevated with the value of 6.0 nanogram per ml. DEXA scan was done, which showed a osteoporosis involving forearm, hip, and the whole on the whole picture there was low bone mass. There was increased fracture risk, and this was the summary that he was having a thalassemia major on long-term transfusion. Cardiac iron was okay, mild hepatic iron was there, and secondary hypogonadism was there, and bone marrow density was compromised.
So we'll start with the question to Dr. Ritika and then Dr. Manisha Kumar. How frequently do we assess FSH and LH? So I'll start with even in the pediatric age group, like Dr. Bhanu. If we have a girl who's having regular periods, a TDT patient or an NTDT patient, when we see them in the clinic, they say everything is fine, my cycles are regular. Should we still evaluate? Should we still look for, or is the having a cycle regularly is indication enough that we don't need to test them any
No,
further?
yeah. Exactly. A regular cycle means everything is just fine.
Okay. So in your clinic, Dr. Ritika, you just mentioned that you do annually you evaluate. So annual evaluation is for everybody, or annual evaluation is those
Yeah,
who
so
have
but again,
symptomatic?
there are we have individuals who have regular cycles and this thing, so they probably do not require this thing. But sometimes, despite them having regular cycles, because we have patients who are older in age, and a lot of them, as we talked about, want to get married and may eventually, want to conceive and have a family in the long term. So sometimes we do tend to assess them, because when we are doing the other endocrine evaluation, we do look at their FSH, LH, estradiol, and this thing, so that because sometimes it may give us an indication whether we need to intensify our chelation further, whether we need to, be more aggressive in our, thalassemia management, and so that we do not miss the bus, because because once infertility sets in, it's difficult to reverse, but I think it is something that we can prevent. So maybe sometimes we do kind of over investigate too, but we do tend to do it.
So is it correct to say that if somebody is planning to marry and planning is desirous of having a family, it should be better to get an endocrine evaluation done with an endocrinologist who has expertise in thalassemia care, right? Okay. So the next question is, like in this case, for example, what are the causes of secondary amenorrhea? I'd start with Dr. Manisha. For in such a patient who has attained menarche, who had regular cycles, and despite being on transfusion chelation, she's gone into secondary amenorrhea. So what are the causes that you would consider in this?
Yeah, so in this, we know that in thalassemia, homozygous thalassemias, there is deposition of iron, and that leads to hypogonadotropic hypogonadism. So and those free radicals also affect the ovaries. The basic problem is this. So I mean, the question is that why they are having these problems, isn't it?
My question is, a girl who had menarche, who had regular periods for a while, has gone into secondary amenorrhea. So in a thalassemia setting, what all would you consider? Is it just poor chelation, or would you consider
Yes.
other causes as well?
Yes. So poor chelation, of course, is the important cause. And the other cause, like as I said, hypothalamic hypogonadism was there. And plus there would be ovarian dysfunction also that I would think of.
Okay, thank you. So Dr. Farooq Shah, would you want to add to any other causes?
No, I totally agree with what's been said so far. The only other situation where we see hypergonadotrophic hypogonadism, which is what this young woman unfortunately has, is in patients who've had a bone marrow transplant. So they, if they've had a bone marrow transplant and then been exposed to the chemotherapy, other conditioning regimes, they can go into premature menopause. And even though they had natural menarche, they may go into premature menopause. So that's the only other time where I've seen it. And that can happen in thalassemia patients who the bone marrow was unsuccessful. So they become thalassemic again after a period of time. They're treated like a thalassemia patient. And then it's very, very unfortunate for this young woman. Her only option in the UK setting or in, in other settings would be the use of an egg donation pregnancy. So it's not that she cannot become a mother, it's about what religious, family, and other issues will allow her to do. That may, the egg donation pregnancy is the only real option that we would be able to offer her.
Yeah. So I'll come back to that bone marrow transplant, take up from there. So a lot of cancer patients or patients who undergo transplant, we generally tell them that if you are wanting to have a family, marry early and have a kid early. So is that true for thalassemia as well? Would you?
Yeah, 100%. I mean, that's what I tell them. If they were lucky enough after transplant to retain their periods, then for the girls, my recommendation is get married early, have babies early. For the boys, I actually tell them they have to semen cryopreserve because they may lose the sperm production as time goes by. And but if they've reached the age of 16, they've gone through puberty, then I'll want them to semen cryopreserve so that we retain that potential for them.
And the cryopreservation, is it the option for these like women also, like the girls also, if they?
Yeah. I mean, if they're going for transplant, so pre-transplant, every
Yes.
single patient should be offered a fertility preservation strategy pre-transplant. So that can include ovarian tissue cryopreservation, egg cryopreservation if the girl is old enough to undergo egg cryopreservation. There's no evidence, obviously, at the moment with testicular tissue cryopreservation, but boys who have started puberty may sometimes be able to produce sperm. So it's worthwhile at least trying to do some sperm cryopreservation for them. If after transplant they are lucky enough to still have periods or go through puberty naturally, and in the male setting, you should definitely try and semen cryopreserve them early.
And even probably embryo cryopreservation if they are married.
Yeah, if they're married, embryo cryopreservation, although we've all heard about cases where, the male partner has said, no, you can't use after a divorce and all sorts of things like that. So we tend to prefer egg cryopreservation, but you can definitely do egg and embryo cryopreservation so that the young woman has a backup in case things go wrong.
And as you showed in your presentation, the last patient who was happy with the adoption, so that also I think we can tell the patient.
Yeah, 100%. So adoption, and because this young man was Muslim, so he could not use a donor sperm. Okay, but in other settings you can use donor sperm and you can use donor eggs. So those are 100% options where religious and societal things allow. And I do tell my patients it's nobody's business whatsoever where the sperm or the egg came from. You don't have to tell anyone. As long as you and your partner are happy with that decision, then it is not important for other people to even be a shareholder in that information. So it depends on obviously religious and other factors, but egg and sperm cryopreservation, sperm donation are both very suitable options.
Yeah, so that's kind of partly answered our next question, that if this lady is desirous of having a child, I would start with you, Dr. Ritika, and then Dr. Manisha. What are the options that you would give in terms of, would you encourage her to try, or would you tell her that it's better to opt for it? So in our country, there are many options for, as in using a donor ovum or a donor sperm. It's just a family's issue. There aren't many religious considerations towards it, I believe. So, and there are many centers that offer also. So, between the three options of having a child of their own versus a donor versus an adoption. So, Dr. Ritika, I would start with you, and then Dr. Manisha. How would you counsel her?
So I think since it is a secondary this thing amenorrhea that she's developed, and another thing, like so she's also become hypothyroid over a period of time. So maybe we can look at what exactly the cause for that secondary amenorrhea is. So it could be multifactorial. It could be something. If it is something that we are able to reverse, then of course she may end up having a child naturally. And if we are able to induce ovulation and help her have a child. And the other option, of course, is to we have the other ways of going about it of preservation and donor ovums and donor sperms, and depending on what the partner and the patient want as an option.
Thank you. Dr. Manisha?
Yeah, so apart from what has already been said, since this patient is homozygous for thalassemia, and if we are using donor egg, we have to probably get that tested because being an autosomal recessive disease, if the egg is again or the husband is normal, then it is okay. Otherwise, the genetic testing would be, advised before we go in for the test. And then we have facilities like PGT available, pre-implantation genetic testing available, so that can also be offered. And of course, when we are doing a PGT, still we need to test once the pregnancy carries on. So that also needs to be explained. So we have to, give them a non-directive counseling basically and tell them what are the possibilities and what they are going for.
Thank you. So, lot of families, when they follow up in a thalassemia clinic, so generally they get married to other patients, relatives, or patients themselves. So, very important that if they are marrying, so where there's high chance, as it is in India, the thalassemia prevalence is around 3 to 4%. So, it's 100 people, four people will be a beta thalassemia carrier state. So, you have to test the husband or the spouse before you proceed. That's point number one. So in her case, incidentally, she married another thalassemia major person. So I don't know, in your clinic, do you have such experience? In which case, it's generally we would opt for, if they are still desirous of having a child, it would be a donor option that you will give, or adoption that you would give.
Yeah, we have love on the thalassemia unit regularly, I'm afraid. We have at least we have at least 3 or 4 couples, thal majors, all of whom have successfully had children actually. And it is usually either using an egg or a sperm donor. But they have all of them actually had children as well. So the answer is you give them the options and then let them decide what's going to work for them.
Yeah,
so I just wanted to
have thalassemia major married to another thalassemia major, and one odd have managed to have children too.
So we'll come back. Another endocrinology doubt rather. So this anti-Mullerian hormone is something I think was discussed in Dr. Shah's presentation as well. So how does that help us now? It's basically indicative of an ovarian reserve, is it? How does it help us does it help us in prognosticating? Dr. Shah, Dr. Ritika, Dr. Manisha.
I'll leave it to the endocrinologist. I know that if it's low, not to worry, but if it's high, I don't know.
Basically, yeah.
Yes, Dr.
Actually,
Manisha. Yeah, okay.
No,
Yeah,
no,
yes, Dr.
continue,
Manisha.
Dr. Banu.
Yeah. Actually, just a disclaimer that I don't know much about AMH, but I know that it is used by the gynecologist and endocrinologist as a marker of ovarian reserve. However, when we talk about male gonad reserves, then definitely, as Dr. Farooq also pointed out, that during the phase of delayed puberty, if your gonadotropins are high, they are rising, that is a very, very bad prognostic sign, because that indicates primary gonadal failure. And when you have primary gonadal failure, no matter what you do, they are not going to respond. The only thing, the best you can do is give sex steroids to develop secondary sexual characteristic. Along with that, there is another way of testing the testicular reserve. What we do, we stimulate the testis with gonadotropin, generally HCG, and there are a number of protocols available. So, and after that, so the idea is that stimulate the testis to maximum and then test the testosterone level. They are always better than any random testosterone levels. So, but my understanding about AMH is limited.
So I also understand that that if there is a high AMH, that means there is a good ovarian reserve, and these patients are likely to respond to ovulation and ovulation induction, and and there is a possibility of fertility, there is a possibility that they would be able to conceive and have children.
Yeah, the good thing about AMH is that you can do it any time of the cycle. And then especially in thalassemia, homozygous thalassemias, you are doing FSH, and it won't be that reliable because, of course, there can be hypogonadotropic hypogonadism part. So it will tell you about the ovarian reserve. But there are other things like doing an antral count that you can do, antral follicle count, and then you can look at the ovarian volume also. It has been seen to be helpful. And of course, you can do estrogen levels. So these are a few of the things that, ovulation is indicated by progesterone levels. But AMH is by far an important thing. And it was nice to know from Dr. Farooq that even if it is low and you stimulate, it becomes okay. So that was good.
Thank you, everyone. So we come to the last case, which is over to you again, Sudeshta.
Yes, ma'am. So this is the last case. This is a patient of transfusion-dependent thalassemia phenotype with poor chelation and primary amenorrhea. So she is a 34-year-old woman having TDT phenotype. She was diagnosed at 3 months of age, and she is on regular PRBC transfusion with a frequency of 2 to 3 weeks. She was on variable chelation compliance, but currently on deferasirox and deferiprone, and she has severe iron overload. So she presented with primary amenorrhea. There was delayed puberty with poor progression. She was having extreme short stature of a height of 142 to 143 centimeters. And her pre-transfusion hemoglobin hovered around 7.5 to 8.5 gram per deciliter. Hepatomegaly was present. So this is the growth chart. As you can see that sorry, BMI was between standard deviation 1 to 2, but her height was less than standard deviation -2. So these were the MRI T2 star findings. In July 2023, she had a cardiac T2 star of 18.4 milliseconds, which has improved to 21.6 milliseconds in last year Feb. And she had also severe iron overload, 0.83 milliseconds in 2023, now 1.05 milliseconds, indicating severe iron overload. So this was the endocrine evaluation. She was having a FSH of 1.9 and LH of 0.8, which were both low, and estradiol of 24 picogram ml, which was also low. TSH, however, was normal. So this was the ferritin range from 8,000 to gradually it had come down to 2,200, and again it just shot up a little bit to 4,900. So she was having low LH and FSH and low estradiol, and bone age was also delayed. So 13.5 years, and she had infantile uterus on USG. So this is just a ferritin chart demonstrated pictorially.
So these are patients who would have come to us for some other reason, and then we picked up all these things. And many a times, patients essentially think that this is okay for being a thalassemic. So nobody would have counseled them that this is abnormal, or you could, if you do this right, this could have improved, so that kind of, so she kind of assumed that being amenorrheic is okay. And she's 34 years and not very far from Delhi. But so this is the kind of scenario. So extreme short stature. So these are things which if we could have picked up early, if they would have presented to a center early, we could have probably improved it at least. So just a question for all the panelists: when should these questions around pubertal counseling and reproductive counseling start in your thalassemia care pathways? Is it as soon as they hit puberty, or is it when they delayed puberty? When do we start it? I'll start with the pediatric endocrinologist.
Yeah,
Then
I think 10 years of age is a reasonable timing, which has been recommended by literature as well. Because by the 10 years of age, we should be alert that, and the family should also be alert that they should be looking for the signs and be aware that in case the things are getting delayed, something is wrong.
Dr. Shah?
Yeah, no, I mean, again, very unfortunate. She's 34 and she doesn't sound like. Has she actually got any secondary sexual characteristics developed, or
Yes,
because
so she
yes.
had, so in the pattern with girls is that they do have secondary sexual characteristics, but they are either amenorrheic primarily, or they have irregular cycles. The pattern with boys somehow, so I'm talking from a purely non-endocrine observation only. The pattern with boys is that, like you just mentioned, they are 21 years and they look like 13 years. So they're completely no secondary sexual characters. So that's somehow a little different in boys and girls.
And girls, yeah. So, I mean, for her, it's very difficult. But I mean, most of this stuff is actually fixable. So apart from her height, obviously, but if you give them estrogen at a proper dose, the uterus does tend to mature. Because obviously she will start to have periods as part of the estrogen progesterone cycle. We would hope that there will be some normalization of the uterus. I mean, certainly at the current moment, she would not be medically fit for a pregnancy or anything like that. But you could work with her, as per my patient saying, knowing that they wanted a child and working towards that child meant that they were perfect with their iron chelation, their transfusion, their diet, their nutrition, everything. If she wants a baby bad enough, then we need a larger uterus. Plus, obviously, some evidence that her ovaries will work. Her ovaries should work once they've been stimulated appropriately, I would say, but her uterus is the rate limiting effect here.
Yeah, so in this case, she's not married, and I don't think she's desirous. She's not even thinking that route. But when we advise that we should see an endocrinologist and should see an adult endocrinologist who will probably advise you this route, her first question is, should I actually do it? Because I'm already 34. Is it required to induce puberty at this age? So that's the question. Yeah.
It's her bone health. We have to remember that estrogen is an incredibly important metabolic hormone. Forget about periods and all the misery that goes with that. But actually, the bone health in her, as well as the emotional, psychological health, is all affected by estrogen. And so we would definitely, and bisphosphonates will not work in fixing her bone density if you haven't actually tackled the estradiol aspects in the, you need all the building blocks. You need vitamin D, you need estradiol, you need bisphosphonates to help fix poor bone density. So I would I would definitely proactively encourage, even at this late stage, proactively encourage her to go through proper hormone therapy and improve all of these things.
And if you see, the bone age is just 13.5 at 34 years of age. So that is so unfortunate. So the body is just stuck at the age of 13.5.
Dr. Ritika and Dr. Manisha, would you encounter these kind of scenarios, and have you induced puberty at this age for any of your patients?
No, I haven't encountered. To
Yeah,
Ritika.
so yeah, we do get patients, and as you're saying, sometimes by the time they come to us, it's already they've already kind of accepted the fact that because they are thalassemic, so it is okay to be short statured. It is okay to not get married. It is okay. No, I feel because they've all their lives they've only been juggling between the transfusion and chelation regime. So no one is really looking at the hormonal and the pubertal and the conception part of the whole thing. So I don't really have experience about hormone induction at this age, but we have definitely offered them hormone therapy, not from a not to probably have children, but as you said, that to improve their bone health and their cardiovascular, because the cardiovascular morbidity and mortality increases as they age, and of course they become osteopenic and osteoporotic and tend to more prone to fractures and injuries and other this thing. So to overall increase their improve their quality of life, we do definitely offer them hormone replacement therapy.
And even at this stage, apart from this, the estrogen is likely to produce secondary sexual characteristics as well as the
Yes.
psychosocial benefits. So definitely that is likely to.
Yeah.
And will
Thank-
chelation help at this stage? Like if we start with, chelations?
Yeah, aggressive chelation helps.
Yeah,
really.
aggressive chelation definitely. Yeah.
So many times what happens in patients who are being treated in tier 2, tier 3, in India especially, I'm telling you, because it's like there is a heterogeneity in healthcare. So in tier 1 cities, there is access to biggest hospitals, and they do see a thalassemia specialist or a comprehensive clinic sometime in their life. At least once in 2 to 3 years, they'll get an access. Whereas in tier 2 and 3 cities, their whole focus is on transfusion. So they keep transfusing themselves. They won't have any splenomegaly. Their pre-transfusion will be perfect, like 12 gram, 13 gram. They'll be all managed so perfectly from a transfusion angle, but they forget to chelate, or they're so scared of chelating themselves. So many times we see them when they are already like 15, 16 years and they're stuck with an endocrine issue. That is when they get referred. So thank you. And so last bit, like last 10 minutes, we'll take on discussing pregnancy. So we'll start with the ped endo section. So I think most of this has been discussed. Dr. Bhanu, anything to add from your side for what we have not discussed for somebody, a girl or a boy desirous of having have a reproductive health later? What should we start? How early should we start? I think we discussed most of this. Anything to add? You're muted, sir. You're muted. Dr. Bhanu, you're muted.
Starting from 10 years of age, if we are regularly keeping an eye on all the possible factors and most importantly managing the underlying condition well, then in case of delayed puberty, if we try to strengthen the things further, and if required replace sex steroids, we usually start with the estrogen to begin with, gradually increase the doses to adult level by roughly 3 years or so, and after that that withdrawal bleedings are introduced. So if those things are done, these are the in general what is done. So after what age with gonadal failure become irreversible? I think the answer to this is not in the age. So we can say that most of the things which are affecting gonads, they are reversible. The only one primary thing which is irreversible is the iron deposition. So it is a matter of time, and that damage is cumulative. So the earlier it happens, the earlier as bad management of iron deposition is there, earlier it will happen. What biochemical markers? I think that has already been discussed. AMH and SCG stimulated testosterone. So that covers my part. Yeah.
Thank you. Dr. Ritika. So during pregnancy, there's a girl who has become pregnant. So how do we manage the other endocrine issues? So there'll be diabetes sometimes on board. So what is your experience in managing this?
Yeah, so hypogonadism, I think we've talked about, and so once they conceive, then of course we need to stop. But sometimes they need to be given because in a normal pregnancy, the corpus luteum takes over and the progesterone is, produced by that. But sometimes in our thalassemic patients, if they may require the progesterone till about 8 to 12 weeks. And in diabetes, normally in a patient in normal individuals, we are only screening for diabetes at 24 to 28 weeks to look for any gestational diabetes. But in our thalassemic patients, if they are not already diabetic, we must, screen for diabetes as soon as they conceive. HbA1c level may not help us. So we definitely need to do a oral glucose tolerance test as soon as they conceive or during the very first visit that they, come for a ANC checkup. And we all understand that, high blood sugar levels leads to a lot of fetal anomalies and also a lot of perinatal mortality. So both these things, are preventable if we manage our diabetes by screening them. And of course, insulin is the treatment of choice along with very strict, lifestyle management. So strict dietary patterns and insulin, though there are some drugs which have been tested, but we do not have enough literature and enough data which supports its benefit in patients with thalassemia, because it is usually pancreatic diabetes. It is usually because of iron deposition in the pancreas. And then of course we've talked about hormone replacement. We need to continue with the progesterone for some time and then wean it off by 8 to 12 weeks. And we do need to monitor the other pituitary functions. Most importantly, we need to look at the thyroid. And so we need to see whether it is a primary hypothyroidism or a central hypothyroidism. In both cases, it would be the management remains the same, that we replace it with levothyroxine. But sometimes if we monitor only using a TSH, we may tend to miss a central hypothyroidism. So we definitely need to look at the free T3 and the free T4 levels also before we, say that no, the patient is euthyroid. And of course, we would need to monitor the thyroid function. Like if we are replacing thyroxine, we would need to keep the TSH somewhere around 2.5 or lower. And we need to monitor more frequently, maybe 4 to 6 weeks, or sometimes even more often. And as we go towards the third trimester, maybe even more often. And of course, we do need to, look at the other pituitary functions. So if we want to look at the growth hormone and this thing, though that is not something that we do as a routine in these patients. And another thing that we need to look at is the adrenal function in these patients, because sometimes, during pregnancy, the adrenal functions are suppressed because of iron deposition, and which may be catastrophic, especially at the time of delivery and this thing. So that is one thing that we definitely need to monitor, like their cortisol levels, or sometimes even the sodium and the potassium give us a clue towards the adrenal dysfunction. And how should we transition from pediatric to adult services for a more structured? I think, as we discussed, if we are priming them from the very onset of puberty and telling them that this part too needs to be looked into, and I think maybe we need to, because at that time they are very young, so we do need to take the parents or the guardians into consideration and counsel them so that they are well transfused, well chelated, and try and prevent as much iron deposition as possible. And sometimes what happens is that, when they come from the pediatric to the adult, this thing, because they are suddenly becoming older and they're looking after themselves. So sometimes, the chelation dips and other, they may not be that regular in following up at the clinic, and they may only be coming for their transfusion and this thing. So chelation is something that really needs to be looked into when we are transitioning from the pediatric to the adult setup. And of course, we need to continue to monitor their reproductive health.
Thank you, Dr. Ritika, for comprehensively telling us what all to monitor during the pregnancy. Now coming to you, Dr. Bhanu, your hand is up.
Just a short comment. Actually, we encounter this situation of transition in type 1 diabetes. When our type 1 diabetes children, they grow. So usually what is recommended and what we also follow, there is some period of say one year or 1.5 years where they are following both the teams. So, but it is important that the other team also understands, and we are kind of understand there should not be conflict of the advices given. So alternate overlap period.
Yeah.
Thank you. So for those of you who joined, there is actually a document which came out, which was published, I think 2 years ago, on how to transition care in thalassemias, which was, so as more and more centers now are willing to take up patients with thalassemia in adult period, it will be easier for us to transition and develop a structured care around it. So Dr. Manisha, I'll actually start from a little early before pregnancy as such. So just basics on screening of the spouse. If it's like a thalassemia major girl who is becoming pregnant or desirous of having a child. So screening for the spouse, when do you advise, what are the testing strategies, etc.? Could you just mention it briefly?
Yes. So basically, as we said, whenever the patient is desirous of having a child, has come in the preconceptional period, again, it is a multidisciplinary team approach has to be there. So you must get the spouse, thalassemia status known before they go into it. And if the spouse is also trait and the girl is homozygous, then they have to undergo the testing. Apart from that, we can start them on, say, like if they have come before, we should know the status. All that Dr. Ritika has already said about the high risk conditions that she might be having. But in early pregnancy, if she's there with us, we have to give her folic acid in like a high dose, 5 milligram that we generally give. And she may be started on aspirin, considering that she is at high risk of having preeclampsia and hypertensive disorders and also FGR later. So she can be started on aspirin, which can be, say, around 150 milligram or 100 milligram also, which is recommended. And then we need to follow, and you need to tell her that she has to come in the 3rd month for chorionic villus sampling, which is the test by which we take out the sample and send it for molecular testing. But before that, we need to test the molecular testing of the parents. So the molecular testing of the girl, lady, and the husband, if the husband is straight, has to be done, because that is the basis by which we will test the fetus. And once we have tested and everything is okay, maybe we can progress. And one more thing, maybe we should be doing the indirect Coombs test, because she has been on regular transfusions. So she is likely to have alloimmunization at this point. And then, of course, we need to follow them. About the preconception risk stratification protocols, we need to see whether she is on chelation therapy or not. Maybe stop that if she is taking, or and then and in any other drug that she has been, probably bisphosphonates or any drug that she has been taking is important. Antenatal surveillance, she will need optimum surveillance, like every month till 28 weeks, and every 2 weekly antenatal checkup till 36, and then every weekly. This is our thing. And there is no special recommendation for mode and timing. It is like according to the obstetric indications. She can go in for vaginal delivery. That is okay. Only thing is need good monitoring during labor. The fetus needs to be monitored by CTG monitoring if facilities are there. And of course, when she in the intrapartum time, she needs proper care because her cardiac, overload is there. One thing I forgot was giving her thromboprophylaxis. That is also an issue. We must consider that. And we have already started her on aspirin, but maybe thromboprophylaxis, if she is high risk, maybe after 28 weeks, she can be started on that, especially during the intrapartum and the postpartum. Even if she has gone for cesarean, then it is needed because she would be rather in bed and not ambulatory at that time. And because she is at risk of PPH and because she is already anemic, during delivery, we need to do an active management of third stage of labor so that, there is no PPH as such. And of course, we need to look for cardiac overload. This is something that is important during this time. And then regular contraception she can have. All that is there in the pregnancy and intrapartum.
Thank you. So this aspirin, I just wanted a clarification. When do you start it? And
Yes, so basically aspirin, if you are starting for preeclampsia or hypertension, it has to be started from 11 to 16 weeks, between 11 to 16 weeks. And it has to be given 1 OD at bedtime. And the compliance is something that is very important. And the recommended dose is 150, but new FIGO classification says that you can take even 100. And seeing the small stature of our woman, 100 also is good, but generally we give 150 for normal prevention of preeclampsia also.
so this is like as per the states. It's not mandatory for everybody, right? It's based on whether you are
Yeah, so it is based on the history or the
proteinuria.
PLG. If you are doing some biomarker or something, and the uterine artery, and the patient comes as high risk. But in this case, the patient is already high risk of having preeclampsia, so she can be started straight away on aspirin.
Okay, so all thalassemia major who conceive are at high risk for preeclampsia.
Preeclampsia
Okay.
or hypertensive disorders and
Okay.
may be started on aspirin.
Okay. And just a follow-up question to Dr. Farooq. I think the next slide is for Dr. Farooq only. But in communities, I just one query. In communities where abortion is not an option, so if a thalassemia major marries a carrier, how do you proceed? Like what is your experience?
So we would recommend pre-implantation genetic diagnosis. So they would go for PGD, and it would be an IVF pregnancy. Number one, we'd cancel them not to do it, obviously. But if they have ended up marrying a carrier, then it would be to go for PGD if termination of pregnancy is not allowed, which currently covers the United States as well as other places. So just on the aspirin issue, there was really, really, really good data from a placebo-controlled randomized trial showing that aspirin use in pregnancy significantly reduced the risk of preeclampsia and all of these things. Thankfully, it was published just before the guidelines were completed, and we were able to incorporate it into the guidelines. So the guidelines do include the recommendation for all women to go on to aspirin from about 12 weeks going up to 16 weeks of gestation as recommended by the obstetric team.
Thank you.
So my questions,
I will put it as a rapid fire to you because you've already covered. So target hemoglobin is 12?
No, so pre-transfusion, we keep the hemoglobin at 10. We don't allow it to go below 10. This is in TDT. In the NTDT patients, the decision to start transfusion is very individualized. Depends on how the baby is growing and how the mother is managing the pregnancy. But generally, if the hemoglobin is below 8, the chances of her needing to go on to regular transfusions is much higher. So the TDT is very straightforward. The NTDT are very difficult. from a decision point of view to manage them at this point. This includes alpha and beta NTDT. Chelation, we avoid. If at all possible, if your patient's doing really well, we avoid, and we go through pregnancy for the majority of girls with only needing chelation on the day of delivery. Because the pre-conception optimization is absolutely key. Dr. Manish has already covered the thromboembolic risk and prophylaxis. So it's individualized risk assessment, set time points, and then a decision on adding in low molecular weight heparin to the aspirin. So those are additional things. Cardiac and hepatic monitoring, that's a really good question. So blood tests for hepatic monitoring, they're done when the patient comes in for their routine blood tests, and that's fine because obviously there are liver complications during pregnancy as well, and thalassemia patients are at risk of that as well. Cardiac, we do a cardiac assessment at 28 weeks in all women who have gone through pregnancy without any problems. And they're seen by a cardiologist with an echo and a formal assessment. And then a decision is made around cardiac risk factors for normal vaginal delivery. If the cardiologist thinks that there's increased risk of the patient going into heart failure, developing complications, then the choice is to go with cesarean. Otherwise, we allow the obstetric and the patient to make a joint decision about what they want to do about delivery and giving birth. So that's their choice. And chelation, it's just, I've seen a patient go into fast AF during labor, cardiac iron loaded patient, and dropped her blood pressure. It was the most scary thing I have ever seen in a pregnancy because you've got two lives that may potentially run into problems. And we know that NTBI levels are very high in pregnant women because they've had 9 months of no chelation. And, you know, free radical damage can, you know, stimulate cardiac arrhythmias. And I think it's a very simple, easy thing to do to give Desferal during delivery.
So Desferal can't we like start after the first 3 months? But why do you say like you don't give chelation at all?
Yeah, so we only give iron chelation during pregnancy in women who have got cardiac iron overload and are at risk of developing cardiac failure, because you've got a healthy baby in utero and you don't want to expose them to iron chelation therapy and then end up with fetal issues, not because of you know, fetal anomalies, but fetal anemia and other things can be equally problematic. So we avoid chelation unless there is a very clear indication for chelation from a maternal perspective. So yeah, that's basically, and obviously we have managed women who have decided to get pregnant with cardiac T2 stars of 7 milliseconds, and we have chelated them from the 3rd trimester onwards. You know, it is very, very individualized based on what you perceive as the risk of that woman decompensating.
Thank you for that fantastic discussion. I think we have few questions in the chat and then we'll wind it up for the day. So I'll start from the top. So I think there's a comment from Mrs. Tole that we encourage transplant before 12 years for this reason of, you know, having. So then there's another question. I think that is answered already. Oh, good. Most of it has been answered. So there's a question. Is CVS/amniocentesis a mandate if PGT-M has been done prior to IVF? I think Dr. Manisha.
Yeah. So yes, even if it has been done, it is recommended that we confirm it later. So you can do amnio as well or CVS, anything, and it is recommended that it has to be confirmed again.
Okay. So I think with that, we come to the end of this long discussion on fertility issues as well as pregnancy. And I'm really, really thankful we got to learn a lot of new points from all the speakers today. And thank you again from our side to all the panelists who have joined in and for that wonderful discussion. So I would request Tuli ma'am for the key messages and the vote of thanks.
So first of all, I must congratulate you, all of you. What an excellent session. It has been all the details, each and everything related to the pregnancy, the pre and the post, and the management and the delivery side. So it has been so nicely explained in the layman's language. And I saw in the chat box that the people were asking for the link. So that kind of an interest. So I'm so happy that the decision we took it in early 2000 to add such type of topics in our conferences. I think it is time now that we have to encourage our patients and the families also that, well, there is a hope, the recommended treatment is there. So let's move forward in life and let our children, thalassemics, lead almost normal lives. So a few points it as take back home messages for the patients and the thalassemia leaders, community leaders, and the parents is, of course, Dr. Shah has very nicely and explained it about the management of the pregnant woman and how to follow the guidelines. And the most important is it is very difficult to reverse in case of infertility. And a very good suggestion that we have to start monitoring our patients from the age of 10. But as a parent, I would suggest that we should start uh, educating the families, parents, because the children at this age are very, very small. We have to start it from 8 years of age because if we start at 10 years of age, I have seen sometimes they do not pay attention and we lose that time. And the delayed puberty has been related to thyroid and to diet and the physical activities, which has been very nicely explained by the doctors. And the treatment is also been explained. And in BMT especially, they said that, well, it is better to have the babies, and as after the transplant is done as early as possible. The one thing which Dr. Michael said and Dr. Shah has also shown in her presentation is that the patients ask such questions that we want to have a purpose in life. That is very, very important. So we need to hold such kind of more sessions in future. And the clear-cut message has to go to the patients. You have a purpose. Look after yourself first. So that's one thing. Then only you will be able to look after others, and then you can move ahead in life, for getting married and to get the employment. And there were certain talks also, the messages about it both are thal. And I'm happy to hear that Dr. Ritika said also mentioned that the two thal majors are married and they have a baby. And that was compared to the UK. So I'm very happy that the things are improving in our country also. But to be very honest with all the experts who are here and the delegates, that there are really certain challenges in our country, not only in India, but the other Asian countries also, where we do not have enough high-end investigations, and the treatment is mostly from the out of the pocket. So sometimes I have seen when we suggest certain tests, are recommended by the doctors, and the families, they really think that the tests are very, very expensive and they don't want to get it done. So these are the certain practical challenges that we have to collectively look at that and address them so that we are able to overcome that and give hope. And of course, not only hope, but in practice, our children should lead almost normal lives. So that's all I have to say. And in the end, I would like to thank all the experts who are here from abroad. And this vote of thanks is from my side, Thalassemics India, as well as from Thalassemia International Federation. I think Dr. Michael is not here. And Dr. Neeta, you have been excellent moderator. And the way the cases you select and put it in front of that excellent session that I have ever attended on this topic. Thank you very much.
Thank you, Ma. I must thank Dr. Sudipto for taking out these cases from our OPD, calling the families and all. Thanks again. Thanks, Sudipto, if you're still on the line. And thanks again to all the panelists. Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye. Bye-bye. Thank you.
Thank you so much, everyone. Namneet, are you there?
Yes, I'll stop the
You
session.
can stop the recording now and you can share this with me. Okay,
Okay.
once it's
Yeah.
converted. Thank
Yeah.
you so much. Thanks a lot for
Sure.
your support.
Thank you.
Bye-bye. Thank you, everyone.
Bye-bye.